All right, Tara, I think you can take it away.
All right. Thank you for everyone for being here today. I appreciate your time. Today, we are going to talk about the many faces of addiction and recovery in St. Joe County, innovations in addiction treatment, moving from vintage models of care to contemporary approaches that support recovery. So, big title, we're going to learn a lot today. I'm Tara Piano, if you don't know that already from our first webinar. I'm a member of the Partnership for Drug Free St. Joe County and in several committees. I'm also the Director of Business Development and Community Relations at Indiana Treatment Centers in Columbus and soon to be Mishawaka. This is the second webinar in three that we're having for the partnership. Just a couple of housekeeping items. If you can make sure you're on mute, I believe everybody is. Please put in the chat your name, your organization, and if you need a CEU certificate, we would be happy to email that to you. We don't plan to take more than an hour of your time, so we are mindful of your time, so don't worry. I think we're going to be very good on that piece. This webinar is being recorded, so we will be able to post that on our YouTube page and our web page as soon as we're able to. And please put any questions you have in the Q&A box at the bottom. That would be much appreciated. We're not going to answer questions during the presentation, but we will after. But please feel free to put those questions in. All right, so in the chat, you're going to find also a character worksheet. The character worksheet is if you have not seen it already from the first webinar, it's something you can complete on your own. It's only going to take a couple minutes. It's a way to humanize your own character that is an addicted person in the community, maybe someone that you know, someone professionally, someone personally. We are not going to call you out on these. I'm not going to ask for them. They're merely for your information and basically what you've learned while you're in this session. Also in the chat, you're going to find links to register for the next webinar that's in November. So this webinar is going to take a deep dive into recovery. I'm going to turn this over to Brian. Brian, I don't know if you know, but I'm turning this over to you for a moment. Brian is the team leader for youth prevention and Camp Mariposa at Oaklawn. So I'm going to let Brian kind of describe that worksheet a little bit.
Yeah, so the idea with this worksheet is that we want you to think about an individual, or you can make someone up if you want, that represents an actual like living, breathing person who is either in active addiction or is in recovery from a substance use disorder. If you have someone in mind, fantastic. We're also not going to specify any particular substance. It could be a chemical substance such as alcohol, cocaine, meth, heroin, or it could be something along the lines of more of a behavioral disorder, something along the lines of food, gambling, pornography. And the idea is that we want to humanize this. A lot of times when we have these sort of get-togethers and we talk about addiction and we talk about treatment and recovery, a lot of times we're looking at it from like a very high level, like a 50,000-foot view of a neighborhood or a community or a region. And so the idea behind this three-part series is to really try to humanize it and think about the person in addiction as opposed to sort of a generalized approach. So keep that in mind as you're working through this worksheet. There will be the September worksheet. So if you didn't get that one, if you weren't here in September, that will be included as well. So there'll be like two worksheets in one, September and October. So this particular one, we're going to be focusing on addiction and recovery. The first one in September, we focused a lot on brain chemistry and sort of addiction 101. So keep that in mind as well. So we will get those posted. I think Janet just posted that in the chat, so you can download that if you need it, if you haven't already received it. And with that, I will turn it back over to Tara.
Thanks, Brian. So right now I'm going to introduce our speaker. We're very lucky to have him. Dr. John Gallagher is an associate professor of criminal justice at Alvernia University in Pennsylvania. He is a licensed clinical social worker and licensed clinical addiction counselor who has worked in addiction and mental health treatment for nearly 25 years. His research agenda is focused on eliminating racial and gender disparities in drug court outcomes the use of harm reduction interventions to support addiction recovery, and also criminal justice reform. He has published over 50 academic articles, such as journal articles and book chapters, and facilitated nearly 200 presentations based on his research. Today's 201, Dr. Gallagher. We are very grateful to Dr. Gallagher for spending time with us today, and I'm going to hand it off to you. Thank you.
Excellent. Thank you, Tara. Thank you all for having me. We'll dive right into the presentation. Just as a brief overview, I'm going to present to no later than 2:10, 2:15 at the absolute latest. And then at that time, 2:10, 2:15, I'll open it up if there's any questions and also comments. We want you all sharing your experiences too, or reflections on this contemporary research. And then we'll make sure everyone's out of here no later than 2:30. I see many familiar names on the attendee list, which is great. It's wonderful to be somewhat home. I lived in Mishawaka, South Bend for 8 years, was a tenured social work professor. While I was there at IU South Bend, I did research and counseling for the drug court. St. Joseph County has a wonderful criminal justice reform system, wonderful treatment court system, and also did work for 8 years for Oaklawn. So I'm pretty familiar and have worked in y'all's community for some time. And as Tara said, I'm at Alvernia University now, which is a small liberal arts Catholic university in Reading, Pennsylvania. And doing work in criminal justice now, but it still intersects, as y'all will hear now, criminal justice system coupled with supporting addiction and mental health recovery. So let's dive right into the presentation. Again, any questions, please just hold off to the end. So the first objective is we're going to conceptualize addiction recovery through a modern lens and explore how vintage approaches to addiction counseling, such as mandating AA, NA meetings, are actually inconsistent with current best practice standards. Ultimately, with this presentation, I'd like to sum it up this way. Do as I say, not as I did. Everything that I will share today as this is best practice is the opposite of what I've done historically in my career. Now, I've worked in the addiction and mental health recovery world for 25 years now, but the way that I was trained in addiction counseling 20 years ago, that was the best training we had then. But for the most part, the way that I did counseling 2 decades ago, today would be considered an ethics violation and harmful practice. And so, not surprisingly, addiction research is evolving every year. Therefore, our practices of how we deliver addiction counseling should also evolve with the science. Unfortunately, and again, this is consistent with research, it takes sometimes best estimates are 7 to 10 years from research to actually hit the field, from science to be implemented into the field. So today, I'm going to be sharing a lot of information of this is best practice, this is not. If you're not fully compliant or following the best practice standards, it's okay, right? It takes time for us to consider and implement these interventions. But we're going to talk about what are best practices today based on science. Number 2, we're going to talk about the hallmark symptoms of the brain disease of addiction. Now, if you haven't, you will. I recently published an article. When I say recently, within the past 6 months, it was this year. And the title of the article is Substance Use Disorder. Addiction is a disease, but not everyone who has an addiction has the disease. That is a different approach than how we have been historically trained. We have been historically trained, if you have an addiction, you have the brain disease. They were synonymous. We now know that that's not true. There are some people who have a diagnosed addiction, according to the DSM-5, and do not have the brain disease. And we now know there are people who have a diagnosed addiction who do have the brain disease. So not only will I talk about it here, and again, briefly and kind of summarize it, but I have a whole article we just published that we'll be happy to share with you all to read through it. But we're going to talk about how people who have a diagnosed addiction without evidence of the brain disease can, if they choose, achieve recovery through reduced drug use. I'm going to reduce my alcohol use to achieve recovery. Or they may use less lethal drugs. So for example, they may say, heroin's created a devastating problem in my life. I want to abstain from heroin, but I'm still going to drink, maybe use cocaine once in a while, marijuana, and they can still achieve recovery. Now, again, 20 years ago, that would have been unheard of, that we're talking about harm reduction in the form of reduced and controlled drug use. So again, we'll dive all into it. People who have a diagnosed addiction without evidence of the brain disease can reduce and control their drug use, and they may choose harm reduction as their treatment goal. People who have a diagnosed addiction with evidence of the brain disease, our best recommendation is traditional abstinence. So we'll dive all into that. Number 3, we're going to identify why drug addiction counselors should not share drug test results and self-reported drug use with the criminal justice system. Simply put, it destroys the therapeutic relationship. To put this in context locally, again, I worked at Oaklawn for 8 years. At Oaklawn as a counselor, if a patient comes to me as the counselor and reports that they use drugs this weekend, as a counselor, I know I'm preaching to the choir here, our response is going to be, thank you for being open and honest with me about your drug use. Let's talk about it. Let's treat your drug use and get you back on track. If the counselor shares that information with the criminal justice system, even legally through a signed confidentiality release, you have destroyed the therapeutic alliance. And without therapeutic alliance, you can't do counseling. We'll dive all into that. When I was at Indiana University, I taught the bachelor's program, Generalist Social Work Practice. It was basically Counseling 101, your very first counseling class. How do you do clinical social work, clinical therapy? And the first thing we say is, as a counselor, you must provide a safe, non-judgmental, confidential environment for people to change. That is the core of counseling. If counselors share drug test results done in counseling, if counselors share self-reported drug use shared in counseling with the criminal justice system, you've destroyed the therapeutic alliance, hence you don't have the core of counseling. Also, then you're not providing counseling. We'll dive into this. Again, a major shift from even how I practiced when I lived in Indiana not that long ago. So number 1, we should not, the criminal justice system, addiction treatment providers such as Oaklawn Life Treatment Centers, under no circumstance should we mandate AA, NA, or other 12-step meetings. If you, as part of your system, again, a treatment system or a court system, are mandating AA, NA, or other 12-step meetings, it is unconstitutional to do so. Hence, you're putting yourself at risk for lawsuits. In addition to it being unconstitutional, there are many other harms that are caused by mandating someone to do some particular type of support group. So let's now unpack both of these points. Oops, sorry. Number 1, it's unconstitutional. So on this PowerPoint, and again, if they have not yet, Tara and her colleagues will be sharing it with you. The link is at the end in the reference page. All Rise, they were formerly known as NADCP, the National Association of Drug Court Professionals. They have a great website that says, do not mandate AA or NA meetings because it's unconstitutional. Click on the link, it'll take you through all the constitutional case laws, right? I'm not a lawyer, I'm a social worker. You don't want me interpreting these laws for you, but this website does a great job of providing a summary for you. To be very clear, here is why they are unconstitutional. AA and NA are Christian religious programs, period. I've been around the field for 25 years. I've been to hundreds of AA and NA meetings throughout my career, particularly early in my career when I was like a counselor assistant. I worked in an inpatient rehab, and I used to be the van driver. I would drive patients to AA meetings and back and forth, did that for years, right? AA and NA, they're absolutely wonderful programs. They've withstood the test of time. They've been around almost 100 years. They're absolutely fabulous programs that we want to encourage our participants to check out for themselves. You cannot mandate them because they are religious Christian programs. And again, the case law is very clear in the website that I offer as a reference. I have seen some people say AA is not religious. It's not Christian based. I don't know what their motive is for that, but they are either intentionally or unintentionally fibbing to y'all, right? I can't speak of their motive, but what I mean by that is, well, the Constitution has indicated in case law that they absolutely are Christian religious programs, but also at AA meetings, they say the Lord's Prayer. The Lord's Prayer is the exact same prayer that I say every Sunday night at my Catholic church. We just call it the Our Father. It's the exact same prayer. And so in no way am I suggesting that AA and NA are not effective programs. I particularly like them. I think they're wonderful support groups. But it's unconstitutional to mandate someone to go to them as part of their recovery support system. In addition, if we put the constitutional issues aside, AA and NA, its culture can be potentially re-traumatizing. Everything that I share with you today is supported by research. The references are all at the end. I can share all the research and want to share it with you. Here's some examples. If any of you have been at AA or NA meetings, the culture is very, I use the word, whatever you want, but intimate. There are a lot of hugs going on at AA. Hey, you're a newcomer. Welcome. Lots of hugging going on at the meeting. Someone like me, I see a friend, I'm very comfortable giving their a hug. Nothing wrong with that. Particularly with women who are involved in the criminal justice system, we have studies where we've asked them, what helps you achieve recovery? What's your recovery support system? And they talked about being mandated to go to AA or NA meetings. And they tell stories about, they have a history of trauma. They went to an AA or NA meeting because they were court ordered to go. They walked into the meeting and a man with probably good intention, welcoming intention, went up to them and said, welcome newcomer to the meeting. And without their consent, he put his arms around the woman and hugged her. We have many women, and I've been doing research on men and women involved in the justice system for 15 years. So we have a decade and a half of research that for some, it seems to be particular to women who have a history of trauma. The intimacy, the hugging that is a norm at the meeting can be potentially re-traumatizing for the obvious reason, them getting touched without their consent, often by people they have absolutely no idea who they are. The other thing we found in some of the research that we did when we did focus groups, individual interviews with women, again, it seemed to be specific to women, is in AA, when we say we're powerless over alcohol, you and I know what we mean. Powerlessness ties back to a diagnostic symptom of addiction, loss of control. Once I start, I have a hard time stopping. I lose control over it. For women with a history of trauma, hearing the word powerlessness can unintentionally be re-traumatizing because it reminds them of the times they were powerless during periods of abuse, during the periods where they were trafficked, during periods of kidnapping or where they were held against their will. Women also talked about, well, we do trauma treatment. And in trauma treatment, like seeking safety, we are taught that we are powerful, not powerless. So again, with good intention, the intimacy, the hugging can create re-traumatization. And with good intention, of course, the word powerlessness. In addition to us not wanting to mandate AA or NA because it's unconstitutional and these issues, AA and NA, they are unfriendly at some meetings. Of course, this is not universal to people who are taking medications, particularly methadone and buprenorphine to support their recovery. Now, in no way would I say that every NA meeting is unfriendly to people using medications. They're not. I've been to many NA meetings that are very open and welcoming. I share this information from NA directly. A few years ago, NA released a report that said some meetings, we as an organization, NA, do not support this, but we do not control meetings. Some meetings may be unfriendly and unwelcoming to people who use medications. And then they give examples. Now, if y'all have been to AA and NA meetings, you know what I'm talking about. Here's an example that I witnessed throughout my years, and also an example shared in the NA document. A leader of the NA meeting may say, hey, Tara, you're on methadone. Thank you for sharing that with us. Because you're on methadone, you're welcome to be here, but you are not permitted to share, Tara. You're not permitted to talk because you're on methadone. We, of course, do not want to coerce and mandate our participants to go to a meeting who are using medication to achieve and sustain recovery, where they're going to be told, and if we break it down and get out of the bushes and break through the BS, they're told to shut up. They're told you can't talk, right? We, of course, don't want to respond to people who are using medications in that way. And so again, in no way is this universal to all NA meetings. I commend NA. They released the report and they said, you should be very selective of where participants go for NA meetings if they choose to go, because not all meetings are kind to people taking these types of medications. Also, mandating AA or NA meetings is the opposite of individualized and person-centered treatment. Now let's take a step back. Do as I say, not as I did. There were years throughout my career, everyone worked the 12 steps, everyone went to AA meetings. I mean, that was the core of treatment of what we did. Nothing else was even explored as an option, right? But to this day, there are many addiction treatment centers that say we do individualized person-centered treatment. And then I may ask them, oh, okay, how do you deal with support groups and helping participants deal with support groups? And they say, oh, every participant must go to 3 AA meetings a week as part of their recovery. Well, I have to say, I'm sorry, that is the opposite of individualized and person-centered treatment. That is templated, one size fits all. This better work for you, and we are dictating what your recovery path should look like, not you. That's not individualized treatment. And so when I worked in Indiana, Judge Woodward Miller, she was the drug court judge for the 8 years I was there, really a pioneer in drug court research or in drug court practice. So she was the drug court judge for St. Joseph County, since retired. She was very selective about where she sent her drug court clients, who she was seeing through the criminal justice standpoint, for treatment. She was very critical because I suspect she knew all addiction counselors say they do individualized treatment. But if everyone has to do IOP, that's not individualized. If everyone has to go to AA, that's not individualized. She was very critical of where she sent her participants for treatment. And she made us, I worked at Oaklawn at the time, prove that we were doing individualized counseling, prove that we were doing evidence-based treatment. I had a conversation with Judge once and I said, hey, I was recently trained in MRT, moral recognition therapy, and we're going to be doing MRT with some drug court clients. And she said to me, great, John, sounds like a wonderful therapy. Prove to me that you're doing MRT. Send me the certificates of all the staff that are doing it. And of course, we were more than happy to email their certificates to say we're doing MRT and we're qualified to do so. In summary, all treatment centers will say they do individualized treatment, and most do. Most do wonderful work. But be very critical, particularly from a criminal justice standpoint, of who you allow to provide addiction treatment to your court-ordered clients and who you don't allow. Make them prove to you that they're actually doing person-centered and individualized treatment. And again, mandating AA or NA is the opposite. It's templated one-size-fits-all treatment. So let me talk with you a little bit about, we'll get into this, but we're going to redefine and kind of explore what we mean about recovery capital. And we'll get into that here in just a moment. So a lot of my work, when I left Indiana University, South Bend, it was during the pandemic. I moved back to Pennsylvania. I first got a job and I became a tenured professor at Morgan State University. It's a historically Black university in Baltimore, Maryland. At that time, it was a great fit for me because my work is on racial disparities and gender disparities in drug court treatment court outcomes. And so in addition to all the reasons I just shared previously of why you should not mandate AA or NA meetings, mandating AA and NA meetings is also one of the factors that leads to racial disparities in drug court outcomes. And what I mean by that, in drug courts nationally, as a whole, again, not universal, but as a whole, white participants graduate more often than Black participants and participants from other races and ethnicities. I spent 15 years exploring this phenomenon. One of the reasons is that White participants in drug courts tended to respond well to AA or NA meetings, meaning they're good meetings, we don't mind going to them. African Americans, they tended to prefer more natural recovery support systems. At no point did African Americans say to me, we don't need a recovery support system. No. African Americans, though, consistently, not in a study, 15 years of studies throughout America, have said in some programs we're mandated to do AA or NA. We don't find it as helpful as utilizing natural supports in our life. So I'm going to share with you a quote. This is one of hundreds, really, if not thousands of quotes I've received from participants doing focus groups, individual interviews through 15 years. I'm going to read this quote verbatim, and that's intentional. Part of my research is to give participants a voice. And so today, I'm giving them a voice. I'll be their voice for you all. So let me read this quote as it relates to this topic. And this is an African-American male who was in a drug court program. In my culture, you don't talk about your personal problems in public. At these AA and NA meetings, these people are talking about how they were abused as a child and how they tried to kill themselves. I can't relate. I have problems, but I don't share them there. I share them with my family. There is this norm that I've learned in the decade and a half of my research that with African Americans, which seems to be distinctly different from white participants, they preferred more natural support systems. As I said, in my culture, we don't air dirty laundry in public. African Americans said, hey, we got just as much dirty laundry as the next person, but we prefer natural support systems. And so African Americans, including a lot of work that I did for African American drug court participants in St. Joseph County, they talked about, yeah, we have much other better supports than AA or NA that we find more helpful. They often talked about religion or spirituality, so attending church, talking to a priest or pastor, but they also talked about, one talked about taking an art class at the community college. Doing an art class 3 times a week helps me achieve and sustain my recovery. Sports such as soccer, basketball leagues. Some even talked about part of my self-care is spending time alone. I'm an introvert. And after I do everything I need to do, attend treatment, do my drug test for drug courts, I like to go home, and part of my recovery support system is Friday night, get some food, be alone, and watch a movie. That's part of their recovery support system. And so in no way am I saying, and I want to be clear about this, but I think you all got it, I am not generalizing back to all white people or all black people as a whole. I'm not even generalizing back to all white people or black people in the justice system. My research is when I say African Americans, I am generalizing back to all African Americans that I've met with in 15 years of research. Qualitative research is only generalizable back to the samples. But I can say without a doubt in 15 years, the views of what helps achieve and sustain recovery support is vastly different, and African Americans prefer natural support systems. So I'm going to give you an example next. I've been doing this a long time. This is by far my favorite quote. I met with an African-American black woman from Gary, Indiana drug court. And I said, tell me about your recovery support system. What helps you achieve and sustain recovery? And here's what she said. When I was getting high, I didn't care about how I looked. I was a mess. Sometimes didn't shower for a few days and never did my hair and nails. Once I got clean, I started taking care of myself better. Every week I get my hair and nails done, and when I leave there, I feel great. My beautician is like my counselor. She hears all my problems and gives me advice. She is a major part of my recovery, and she knows I am in drug court and all the challenges I face. The court makes us go to NA meetings each week, but I find getting my hair and nails done is much more helpful. NA meetings can't make me feel beautiful. And when I feel beautiful, I am less likely to relapse and more likely to complete drug court, period. End of quote. Again, when I started in the field, it was everyone go to AA or NA. And someone said, could I use my beautician as my recovery support system? We would say, no, of course not. You go to AA and NA and you work the 12 steps. Well, science has evolved that has made it very clear, and it goes back to that last point on the other slide about recovery capital. Recovery capital is anything and everything that helps you achieve and sustain your recovery, and you as the patient are the expert of your recovery, not me as the therapist, not me as the judge. Participants are the experts of their life. They are the experts of their recovery. We as clinical social workers are experts of delivering good quality treatment. Judges are experts at doing judge stuff. Probation officers are experts at doing probation officer stuff. But Recovery Capital says you, the patient, will teach us what helps you do well in drug court, what helps you sustain your recovery. And if someone says it's an art class, a basketball league, watching a movie alone Friday night, or their beautician, that is what should be incorporated into programming, into treatment plans. Point 2, objective 2, addiction is a disease, but not everyone who has an addiction has the disease. I talked a little bit about it earlier. Let's dive in deep, give you a little bit more concrete information. In the DSM-5, there are 11 diagnostic symptoms of addiction. So addiction is not a word we just use freely, right? There's actually evidence to show that someone has either a mild, moderate, or severe addiction. So whether someone has mild, moderate, or severe, the criteria and numbers needed are noted there. Those with a mild addiction, you'll also hear called a mild substance use disorder, they have an addiction, they do, a mild substance use disorder. So they have a diagnosed addiction and they do not have evidence of the brain disease. Now, that doesn't mean addiction is progressive. That doesn't mean they're not in the early phases of addiction and it may progress to a moderate or severe later if they continue using. It may, but not always, right? There are people that have a mild substance use disorder. They do need to change their relationship with drugs somehow, abstinence perhaps, or reducing their drug use, right? But not everyone who has a mild disorder, not everyone has the progressive disease. So the evidence of the brain disease, and we'll get into it in the next slide, is tolerance, withdrawal, loss of control, and craving, okay? So you will see people who have a severe addiction, they have 6 of 11 symptoms, right? That means they would meet a severe substance use disorder. We know that about 95 to 98% of people who have a severe substance use disorder they'll meet at least 6 criteria, of course, but they will always meet these 4 of the 6 or 4 of the 11. Tolerance, withdrawal, loss of control, and craving. Those 4 symptoms are the evidence and diagnostic criteria for brain disease. Now you can see why someone who has a mild disorder does not have the brain disease. These 4 symptoms, tolerance, withdrawal, loss of control, and craving, they cluster together almost always. I mean, if you have one, you got the other 3. They cluster together. So if someone has 4 symptoms, they now have a moderate disorder. You will see for someone who has a mild substance use disorder, again, they only have 2 or 3, they will meet 2 or 3 symptoms, but the ones they won't meet will be tolerance, withdrawal, loss of control, and craving. Let's dive into it a little bit. So the hallmark symptoms are here. They're what I've just previously repeated. These hallmark symptoms, these are 4 of the 11. For someone who has a severe substance use disorder, these 4 symptoms will almost always, we're talking up to 98%, be present. And you know this, if you've been doing addiction counseling long enough, oh yeah, people who have a severe substance use disorder, these 4 always show up. And they also cluster together. If someone has craving, they have the other 3. They almost always cluster together. So this is the evidence of the brain disease. So kind of in summary, abstinence. So traditional abstinence, which we have historically recommended in the field, abstinence is recommended for people who have a diagnosed addiction and evidence of the brain disorder. We know that they are typically, almost always those that have a severe addiction, but also those that have moderate addictions. Harm reduction, and I'm talking about harm reduction. I'm not talking about giving out clean needles or giving out Narcan. Not that that's not good harm reduction. I'm talking about harm reduction in developing a treatment plan where Tara's goal is to abstain from heroin, but to continue using marijuana and alcohol. Harm reduction in treatment planning, reduced or controlled drug use, using less lethal drugs, can be successful can be a successful treatment goal for people who have a mild substance use disorder, hence people who have a mild addiction with no evidence of the brain disease. So again, I'll move on. We have a whole article I wrote about this. And not only did I write the article, we give example treatment plans about here's a successful recommended treatment plan for someone who has a mild addiction and not the brain disease. Here's an example treatment plan you could use. Here's why we're recommending abstinence for someone who has a severe addiction and evidence of the brain disease. Now, part of the reason we're recommending abstinence is the other forms of harm reduction, reducing their use or controlling their use, requires what? Control. People who have the brain disease, they have demonstrated they meet the diagnostic criteria for impaired control, loss of control. So historically, we've recommended abstinence, but we have moved from not everyone needs abstinence to achieve and sustain recovery. And if someone has a mild disorder and is still using cocaine and still drinking, but their cocaine use and alcohol use does not have a negative impact on their life or functioning, they do not meet the criteria for addiction. Drug use alone in no way means addiction. It must have a negative impact on your functioning. Number 3, addiction counselors, and I'm just using Oaklawn as an example because it's local and I work there. Addiction counselors at Oaklawn should not share drug test results done in counseling and self-reported drug use shared in counseling with the criminal justice system. We hear this a lot. They say, we want addiction counselors and the criminal justice system to be on the same page. We want Oaklawn and their counselors and the drug court to be on the same page. And I say, you absolutely, it sounds good. You absolutely, under no circumstance, want counselors and the court to be on the same page. And if indeed clinical licensed social workers are on the same page with the criminal justice system, the clinical social worker is committing an egregious ethics violation where they could potentially lose their license. Let's talk about it. It's okay to say, I know it sounds good, we want everyone on the same page. No, you don't. You don't want counselors on the same page with the criminal justice system. For example, a court, Judge Woodward Miller, again, a pioneer in drug court, in my opinion, a great drug court judge. St. Joseph County does excellent work. A judge can say, if you want to do drug court, you must do counseling. The chief of probation, Jesse, he could say from St. Joe County, if you want to do this program, drug court, you have to do counseling. You don't have your court ordered the counseling if you want to do drug court. There is nothing wrong with that. Under no circumstance can a clinical social worker ever tell a patient that they are mandated to counseling and that the social worker is mandating them to counseling. That is the opposite of all values of social work. It would be an egregious ethics violation for a social worker to mandate counseling. Number 2, a court can say, the judge from drug court can say, you want to do drug court, you have to do counseling. And when you go to Oaklawn, you better sign this confidentiality release form because I need to know what's going on at Oaklawn. Under no circumstance can a clinical social worker, licensed professional counselor, certified addiction counselor coerce or even create the perception of coercion in signing a confidentiality release. If a clinical social worker said, here's a release for drug court and you must sign it, that's an egregious ethics violation that violates all of our values of self-determination for the clients that we serve. They have the right to choose. We don't want counselors and the justice system on the same page, and it's okay that they're not. Third point, requiring a level of treatment. A judge can say, you were assessed as needing inpatient treatment. The client may need inpatient treatment. You can't stop using. You need to get the detox and need to go to inpatient. The drug court judge can say, you need to go to inpatient treatment. You don't have an option. I'm court ordering you to inpatient treatment. Under no circumstance can a counselor say you must go to inpatient treatment. A counselor can and should do an assessment. A counselor can and should make a recommendation, but under no circumstance, again, it would be an egregious ethics violation if a report of a clinical social worker said to a patient, you must go to inpatient treatment. It's okay not to be on the same page. And we need to actually separate and reduce our collaboration. Let me wrap up with a couple quotes and then we'll open up for comments, discussion. Here's what happens when drug counselors share information with the courts. Here's what it looks like. And we have published a dozen articles now on this topic, that if you want people to do counseling, you must separate counseling from the court. Hence, counselors should do drug tests, and they should be used for clinical purposes, never shared with the system. Should people in drug court do drug tests? Yes. And the court should do that, not Oaklawn, not the treatment center. Here's what it looks like when treatment shares that information with the justice system. It destroys the therapeutic relationship. Quote, I relapsed once while in drug court, but the judge didn't know about it because they didn't pick it up on a drug test. But it wasn't something I wanted to do, so I discussed it in group. Our counselors always talk about being honest, and honesty is the key to recovery, and nonsense like that. So I went to group, was honest about my relapse, and then the counselor called my case manager, snitched on me, and I went to jail. Honesty is not part of my recovery, and I can speak for all of us. All we do is lie to the counselors and tell them what they want to hear because no one wants to go to jail. End of quote. If the justice system wants patients to get good quality treatment, what's the core of good quality treatment? The safe, non-judgmental, confidential environment where patients are in charge of their recovery because they're the experts, not us. If a counselor shares a drug test result or self-reported drug use with the justice system, again, we got 15 years of evidence, over a dozen peer-reviewed journal articles published on this, right? You are no longer viewed as a clinical social worker. You are viewed as an extension of the criminal justice system. You are viewed as a glorified probation officer who works out of a therapy office. This is a vintage, or that model of oversharing information is a vintage approach. Some major organizations have come out with reports recently and said, yes, we need to separate, let counseling do counseling and let the court do the court thing. If you're going to do a drug test that could result in a sanction, a consequence, incarceration, that drug test needs to come from the justice system, not from a clinical setting. The last quote, then we'll open it up. It ties right back into this theme. Again, participants' quotes are the best. They summarize it, they conceptualize it best. I feel that I won't graduate drug court because I'm not receiving good treatment. I have a really serious addiction to heroin. I think about it all the time and constantly obsess about using, but I don't want to get high in my heart, but my mind does. If I do relapse, I have no one to talk with it about, not even my therapist, because if I tell them, they will tell drug court and I will go on sanctions. It's a real shame because we need a safe place to talk about the challenges we are experiencing and a safe place to treat our addictions, but this court does not have that. End of quote. We need to separate counseling and the criminal justice system. We can still collaborate, but we need to separate and be very clear about what that collaboration looks like. Because we may say participants are lying. They went to counseling and they said, no, I didn't use drugs. I didn't use drugs. And then they tested probation or wherever and they test positive for cocaine, right? They're lying, right? Well, I would say, yes, they're lying, because we've created an environment for them to lie. Now, don't get me wrong. I'm not the type of person to blame others, right? I take responsibility for my behavior, right? I'm not to blame others, but I am saying we as counselors, we are responsible for creating a safe environment for participants. And if you as the counselor share something with the court and the patient goes to jail, that is not a safe clinical environment. So if they come back to you and lie, all of human behavior knowledge would support that. And what I mean is we as humans have basic needs: food, water, shelter, safety, and freedom. And if any of our basic needs are compromised, so if I have a baby and my baby hasn't eaten in 3 days and my baby goes another couple hours and doesn't eat, I will run into Walmart and I will steal. I will break the law. I will steal formula to meet the basic need of my baby, to keep my baby alive. The same is true with freedom. These participants aren't lying because they're liars. Some people lie for manipulation. That's a different context. They are lying because counselors have said, you can be honest with me. This is a safe place. They were honest and they found it wasn't a safe place because they told the court and they ended up in jail. We as clinical social workers, we can successfully collaborate with the criminal justice system, but we need to have a very candid discussion about what that collaboration looks like. So again, We don't want to mandate AA or NA meetings. It's unconstitutional, as well as other potential harms. We want to identify who has an addiction and the brain disease and who has an addiction and no evidence of the brain disease, because that will actually inform our treatment planning. And for some people, reduced and controlled drug use, they're still using drugs, may be their path to recovery. And then, as we just talked about, we have to have candid conversations nationally about how clinical social workers, counseling agencies collaborate with the criminal justice system so the justice system can do their thing, protect the public. And we want that. And that Oak Lawn and other counseling agencies can do their thing. They can support the patient and prove and show patients, we work for you, the patient. We don't work for the justice system. And that's the core of clinical social work. So with that said, again, my email's here. All the research I've talked about is cited here, websites, and I'm happy to share it all with you, at any point now or after the training. So at this point, I'm going to stop to share, and I'll flip it back to Tara. I'll flip it to you, and then we can kind of decide where we want to go from there.
Thank you. Wow, that was really interesting. Thank you. I love hearing the drug court quotes. Those always get me every time. Okay, so do we have any questions? I don't see any in the Q&A. Janet, do you see anything out there?
Yeah, we do have one in the chat. So
Okay.
the question is, why recovery? Why not just healthy living? We're trying to change the definition of recovery, but it's been used for so long to mean abstinence that I find reframing. Let me keep going down here and look. Reframing. Sorry. Oh, my bad. Hang on a minute. I got to get down to it. Let me get back up here just a little bit. All right. So reframing it. All right. Well, anyway, and it's about accepting and managing their like diabetes when we do that and those kind of things. And it feels like we want to call substance use disorder a disease, but we don't treat the patient the way they would be treated for other diseases. So in that concept, so John.
Whoever wrote that comment, amen. Yes. Call it whatever you want. And what I mean by that is I like the point made in the comment about, recovery. I like that word, but it does have a historical context to it that is historically tied to one thing, abstinence. So the idea of even reframing it as healthy living, I love that, right? And I really think that is a holistic approach. And a really contemporary approach to addiction recovery. So amen to that. Yes, I love it, right? Your intention of it is aligned with contemporary science. I would even take it a step further. We as a profession or as professionals, I think we provide some guidance, such as, what do you think about healthy living? Some suggestions. But a judge, this was a drug court judge from from Louisiana, said this to me. She said, here's how I define recovery. She said, here's a big mountain in Louisiana and recovery's at the top. And if I hypothetically have 1 million patients in my drug court, there should be 1 million different paths up the mountain to achieve recovery. And there should be 1 million different definitions of what recovery means. And I said, amen, Judge, that's individualized treatment. So even rather than us saying, here's what recovery is, here's what healthy living is, I think we could say to participants, hey, let's talk about, you're going to hear the word recovery a lot. You're going to hear the word healthy living, right? What do these words mean to you? You do want to change how you use drugs, your relationships with drugs. You don't want drugs to create problems in your life anymore. If I just started here, the word recovery, what does that mean for you? And let them define it for themselves. And they may start talking about healthy living and then feeling healthy spiritually, of course, mentally and physically as well. So yes, I agree. I think, again, Judge said it best. If you have 1 million patients, there should be 1 million different definitions of recovery. We don't need to define it, because patients should define it. We support them in it, and we don't just say, hey, define recovery, go on. Of course not. We say, and this is what I say, to me, I say to patients, here's what recovery means to me. It means improved quality of life. What's your thoughts about that? Someone may say, hey, you hear the word recovery a lot. To me, it means healthy living. What's your thoughts about that? So I think it's a great point, and that point is absolutely 100% aligned with contemporary addiction science. The clients define recovery in their goals, not us. We support them in that process. We give recommendations. If someone has a severe addiction and evidence of the brain disease, we should be recommending abstinence as a goal. If they choose not to follow it, that's okay. They have a right to not follow it. And we meet them where they're at in a clinical setting. So yeah, excellent point.
We have a question here from Jesse. Our risk assessment tools indicate that an individual is in need of pro-social supports. If a defendant is utilizing their natural support system but continues to test positive, can we require other peer or social support meetings, not necessarily NA or AA, even if it is not their natural support system?
Right. So great question. And so to answer the question, no, but let me explain when I say no. So if someone is utilizing their natural support systems, that's good. That's consistent with recovery capital, individualized treatment, person-centered treatment, but they're continuing to use drugs. They can and should continue to utilize whatever support system they want. The thing that may change is their level of treatment. So they're continuing to use drugs. They should continuously be assessed. And the therapist from Oakland may say, you know what? We assessed them. They were doing individual therapy once a week. They're using quite frequently now. They don't need inpatient, but they do need IOP. And so that person, if they continue using drugs, they should still have full autonomy in what their recovery support system is. But their level of treatment may change. Because, and this is an example from Iowa, I did work with treatment courts in Iowa a few years ago, and they said, we don't mandate AA or NA meetings. Our policy and procedures says you can go to an AA, NA meeting, or Celebrate Recovery, or Smart Recovery, or some type of formal support group, right? Now, providing a secular option like Smart Recovery is a good thing because it's no longer unconstitutional as long as you have an option, right? But that is still not consistent with person-centered individualized treatment. And so we worked with the Ohio or the Iowa treatment courts that their policy used to say in treatment court, you must utilize some type of recovery support group, AA, NA, Smart Recovery, et cetera. It now says you must develop and utilize a recovery support system while in drug court. And your recovery support system can be anything. Hiking, watching a movie Friday night, a beautician. It can be anything. And our expectation is that when you meet with the judge each week for a status hearing, when you go to Oakland for counseling, we're going to talk with you. What is helping you achieve and sustain your recovery? Teach us about your recovery support system. So yes, we still in that situation. Great question by Jesse. I bet that guy's like the chief of probation in St. Joe County. That guy knows what he's doing. They do good work in St. I tell you, top notch, the drug court and probation system there in St. Joe County. But no, don't change the recovery support system. They still have to do something. Don't change the recovery support system. But in that situation, you may have to change, meaning they may have to intensify their level of care.
Brian, Janet, do we have anything else?
I do not see anything else. I don't know if Brian has or not.
No, there are no more questions in the Q&A, and I don't see anything in the chat.
Wonderful. Well, thank you, Dr. Gallagher. We really appreciate your time and your expertise, especially in St. Joe County. The point of this webinar series is to be more specific to St. Joe County and surrounding counties. So I really appreciate your time.
Yes, absolutely. And if I can, just real quick.
Yeah.
Out of the articles I published over 50 academic research studies. Nearly half of them are from St. Joe County. And so, I mean, I share that of like St. Joe County is not only doing great work, but they're pioneers as a whole, y'all county of advancing this science, particularly in treating addiction in the criminal justice system. Sorry for interrupting, but I wanted to share that rightful kudos to y'all.
Thank you. Okay, well, if there are no more questions, and in the Q&A or the chat. I would just like to remind participants here that it would be wonderful if you have not filled out your worksheet yet, fill it out. Next month, we're going to have another webinar and you can take it along with you. We'll send you a new one for the third webinar and we'll go from there. So please see in the chat the invite or the QR code, excuse me, or the link to the next webinar. And that's all. Thank you so much, everyone. Thanks, John.
Excellent. That met y'all's needs.
Of course. Have a good one.
All right, take care. Bye. Thank you.
Bye.